Hi, I'm Dr. Yasser Rifay from Morocco. I'm happy to present you this presentation about some clinical cases that shows the help of epithelial mapping in suspicious cases of early keratoconus. Case number 1. So this is a patient that came for refractive surgery and we've done for him this pentacam. This is the right eye, this is the left eye. In this patient, we noticed some abnormalities. We have in the right eye a skewed radial axis. We have abnormal IHD in the right eye. In the left eye, we have asymmetry that is more than 1.5 diopters, and we have abnormalities in topometric indices IVA, IHD, and TKC that shows that it is a possible keratoconus. So this is a borderline case because there is an abnormality in the anterior surface, but the posterior elevation is normal. This is the anterior surface by the MS39 for the same patient, and we notice this asymmetry more than 1.5 diopters in the left eye. The epithelial mapping shows a normal shape in the right eye, which is thickening in the inferior side of the cornea and thinning in the superior side of the cornea. And this is the same in the left eye. We have thickening, inferior thickening and superior thinning. This is a normal shape of epithelial mapping in this eye that shows, and we confirm that there is no scars and no haze in the stroma, and we confirm that this abnormal case or this suspicious case is not a keratoconus, and it is a false positive by tomography. Case number 2. This is a case of a left eye of a patient that shows a little suspicious cornea by asymmetry in the anterior surface by pentacam, but normal elevation in the posterior elevation by BFS. We have also done the Belin-Ambrosio display that shows normal elevations. We have an abnormality in these factors, but this is due to thickness, but not to the elevation that are in green. So this shows that this cornea is suspicious, but couldn't confirm if it is keratoconic or not. In this case, we made the epithelial mapping that shows this thinning over this zone of steep cornea. So this is a steep cornea with asymmetry, normal posterior elevation, normal Belin-Ambrosio display, but there is a thinning over the steepest area, an inferior thinning, which is a donut image, and this is confirmed that it is a keratoconus because the fellow eye is a patent keratoconus in pentacam in other devices. So the right eye is a keratoconic, confirmed keratoconic eye. In the left eye, it is a suspicious. So this example shows that pentacam didn't show confirmation of keratocon in the left eye, but it was shown only by the thickness of the epithelium by the epithelial mapping. Case 3. In the case 3, we have abnormality in the anterior surface, the asymmetry that is more than 1.5, but there is here we have normal elevation. We have this island, but the elevation, the value of elevation is plus 10. So the plus 10 is a normal elevation, and in this case it is a suspicious case, suspicious cornea, but we cannot confirm that it is normal or abnormal. And Bina-Ambrosi display shows a normal elevation, anterior and posterior elevation, even in BFS and Bina-Ambrosi display. So with pentacam, in this case, we cannot say if it is a normal cornea or it is really abnormal. We can say only it is a suspicious case. This is the epithelial mapping of this case that shows a thinning here in this area where there is a stiffening in the pentacam. So this confirms that it is an early keratoconus, and it is not now a suspicious case, but it is a confirmed case of keratoconus only by the epithelial mapping. And we know that it is a keratoconus because the fellow eye is a confirmed keratoconus by pentacam. So this led us to say, is pentacam or the sham flow cameras or tomography enough to detect the very early keratoconus? The anterior surface can be altered by or sensitive to the abnormalities of tear film, the abnormalities of epithelium, the abnormalities of other things, of rubbing. The posterior elevation is sensitive, but when the keratoconus is too early, the elevation cannot detect the very abnormal elevation of the posterior surface. Epithelial mapping is a huge development in corneal imaging, so we know that epithelium is not homogeneous, and irregular stroma leads to irregular epithelium. This is a theory of Dan Reinstein about this technology. In this case, we have abnormal anterior surface, normal posterior elevation, but the epithelial mapping shows that there is a thinning. So this is this case where we have small abnormalities of the anterior surface, which is in red. We have small abnormalities in the posterior elevation, which is not detectable by pentacam in BFS mode or in Bina-Ambrosi display, but it is detectable by the epithelial mapping that shows this this island of thinning. The first case showed an irregularity of the anterior surface, which is here in red, but the thickening of the epithelium in this side shows that it is only epithelial hyperplasia, and that this is not a keratoconus. So in this case, we can exclude the keratoconus using the epithelial mapping. But in this case, in thickening, when we have thickening, we have to examine the cornea by slit lamp and by OCT scans to see if there is any scars. This is the behavior of epithelium in keratoconus. It thins in the surface and thicken around it to make the surface of the cornea more smooth, and this is the real shape of the cornea, and this is the shape that it is modified by the epithelium. The filling effect of the epithelium when we have scars, when we have gaps. So normal epithelium is regular, is asymmetric. There is a temporo-superior thinning because of movement of eyelid, and there is a difference about 5 microns between superior and inferior side. It is sensitive to contact lens wearing, to dry eye, surface diseases. And abnormal epithelium shows in keratoconus a donut image like this. When we have thin, it is the thin area over the peak and a thickening around. This is another case. There is thinning and thickening because the keratoconus is asymmetric. It's decentered cone. And as you see here, the epithelium is like a lens. It's like a contact lens that try to correct the aberration and the asymmetry of the stroma. This is a case where there is a thickening over the peak, and that exclude the keratoconus, but we have to be aware about the scars. We have to look for scars in the cornea. If there is a scar, this image is not reliable. This is a case that we have a thickening. So if we have this thickening over the peak, we cannot say it is not a keratoconus because we have to see the OCT scans. If we have OCT scan, the scars in OCT scans, we cannot rely on this epithelial mapping. The epithelial mapping is not helpful in the diagnosis of keratoconus when we have a scar in the cornea. Also in this case, we have the thickening here. If we have a cone here and a thickening here, but it is not reliable because we have a haze here, and the haze is a scar, and there is a filling effect over these small scars that gives this false images. Another case with scars and filling effects. So in epithelial mapping, we should analyze the thinning, the thickening, the average thickness, the shape of the epithelium, the location of the thinning and the thickening, the difference between the thickest and the thinnest point that can give us an idea about the level of the keratoconus. And we should always correlate epithelial mapping to slit lamp examinations, look into scars or haze, high definition OCT scans, curvature maps, elevation maps. All these parameters should be examined, and epithelial mapping is not reliable in detecting early keratoconus in corneas with scars. Thank you very much for your attention.